So concept is very similar. You have some sharp edges, and we are working actually making F&B needles. We are almost there with the needles, and once it's established in our setup, making it commercially available is a longer journey. But I think it will be. The cost difference at the moment, if we use the same handle, which everything comes in the needle, and we just replace the needle, the cost of F&B needle to us now is at the moment is going to be 10,000. We actually use it all, at least public, because when we make check, it's 6,000 rupees, and we made savory wire, it's 1,000. We don't hardly use the second time. US and with FNA, then rose is very useful. Without that, it's not recommended. Can you do it without that? Well, you can, but you'll not be able to assess the tissue that well. So once you've got rose, now I'll tell you why rose has become easy. And then EUS FN needles are much cheaper than FNB. Okay, so keep that in mind. And rose, with what we have shown you, so with this, they have high quality of evidence as well. ESG suggests using end-cutting FNB needles rather than reverse bevel FNB or FNA needles for the histopathological diagnosis of autoimmune pancreatitis. There's a strong recommendation, but evidence is very weak. When you use fanning techniques. There are other methods as well. There's a talk technique, which is very similar. The idea in talk technique is the same, but I think majority of the people I know use fanning now. So this is just for. So once you've got the needle in, you're doing fanning. How do you? What do you do? Do you apply suction? Do you do slow pull, or do you take the stylet out completely and just go? I think ESG recommends equally the wet suction or slow pull techniques for US FNB of pancreatic masses because they provide high rates of adequate samples and tissue integrity and reduce specimen bloodlines compared with dry suction. Now this is where we've had this discussion that there is no I no real hard evidence to support one or the other. Just do what you do. I personally feel that, you do something because you're doing regularly, you see what is good for you, and just stick to it. As long as you're getting good samples, that's what matters. The idea here is, so what is slow pull? You have a stylet. As you're going in, and now the stylet is being pulled by by your nursing or technicians. So the idea is that it's actually creating a negative suction, so the tissue is actually coming in. Slow pull is that no suction. Basically, just you take the stylet out and just keep going in. Dry suction is when you attach a syringe which has a vacuum or suction capability, and you just attach it to the syringe and it creates that negative pressure. The problem is that it usually brings more blood as well. So it's a little bit more bloody when you do dry suction, if the tumor is vascular, obviously. Wet suction is you prime the needle with water, okay, and you put 2 cc's saline in your syringe, and actually the concept is that as the water is being pulled into the syringe, again a vacuum is created, or a negative pressure is created so that the tissue can actually come in. All of these are, as Khalid mentioned. So how many times do you have to actually do to and fro movements, number of actuations? Again, there is a trial which has looked at different numbers, and what they've come up with is that 15 is better than 5. But overall, there's not very hard evidence to support. One thing that is recommended is that anywhere between 10 to 15, and I think that's probably what most people end up doing even before you realize. And each to and fro movement should ideally cross the entire diameter of the tumor. And that's important. If you're going through the tumor, you just don't want to go in a little bit, come out. You make sure they literally go to the end, come back, and then go and come back. And the way, I think panning हमने आपको दिखा दी थी. It's basically the elevator and the big wheel. Those two are used to actually change the course of your needle. Number of passes, I think there's consensus that it should be at least 2. Okay, if you got good tissue in 2, then that's good enough. Otherwise, you go on until you get good tissue. So, specimen handling and processing, conventional spares, cytospins, LBCs, as long as you've actually spoken to your lab. And what we've done is we got the lab guys, because we don't have a lab here. Like, they have literally a cytopathologist sitting in their office, and a cytotech as well, and they've got the labs very close. I think it's important that you bring the lab guys, make sure you're collecting the specimen correctly and in the correct container, because I've seen that has been a big problem. Slide making is very simple. Actually, I wasn't, I first went to the course in Florida, and that's where I had that session, and they actually made us make slides. And then I came back and I said, well, so we got the cytotech here for 3 days, 3 or 5 days from Shawakana. And then we went through slides. We had 2 techs who we trained, and then we were okay. So when you're dealing with pancreatic cyst fluid, volume less than 0.5 ml, biochemistry or molecular testing with cytology, and for volume more than 5 ml, cytology, biochemistry. I think the most useful test now for just sample is your glucose, where you can do CEA, and obviously you can do amylase where you suspect. Molecular testing, I think you can collect the sample, and there's a company here that sends it abroad, but the cost obviously is a major issue. Do we need rapid on-site evaluation for FNB? And general consensus, you don't need it. But a lot of centers who already have established rows continue. We also continue. I think it's just that, I think that part is very useful for us for not only this, but for cytology, doing bile duct cytology or spy bites. We do touch maze, and that's it's good to see that. Again, Khalid was here, and I asked him, their are better than obviously quite a lot of centers, and they do that. Correct me. Yeah. So these are, they've looked at it, and we've already discussed this. Now this is important. We've seen this only yesterday. So the slides we made, put it on ChatGPT and actually describe the whole slide. So there is room for obviously AI here. There is room for you because we have a Wi-Fi connected microscope. So we can actually send the samples even if you want to their center through Wi-Fi, literally almost as we are looking at it. If you have a cytopathologist available, you can actually do that. So now that's where we were discussing. FNA needle, making FNA needle is the easiest. FNB is obviously technically difficult. FNA is not a problem. Now, if FNA needle is very cheap compared to FNB needle, and if you have rows, FNA needle would probably give you almost similar results. So if you are really stuck with cost and we are not getting FNB needles in our part of the world, then I think doing and using FNA needle with rows may be an alternative, but a much cheaper alternative, because the cost of FNA needles will keep going down. So this obviously makes it, so you've heard these terms, macroscopic on-site evaluation, where you're actually measuring the macroscopic tissue that you've obtained. Then you have different types. Obviously, the less bloody, the better, but depending. So, for example, neuroendocrine tumor would have vascular versus pancreatic cancer, where you'll get this. Sorry. Visual on-site evaluation is just looking at the same thing, not measuring. But if you've looked at it and you think the sample size looks about 1 centimeter, which is this much, then it should be good enough. And they've actually quoted 4 mm as well. But in our experience, the small samples almost always the result comes back not enough. 4 mm, it's very unlikely that I would get from the. So, but this is something that you also saw. That's a stereo microscopic on-site evaluation, which is that little camera that gives you 30 magnification into 30. So actually, you can see the core mixed with blood or otherwise much better. So I think it's not a very expensive thing, and it's probably worthwhile if. Soul is basically using this device. You saw that, it's a microscope, stereo microscope that only gives you. Just magnification. So, are there other techniques that help us? Yes, contrast enhanced EUS. Randomized trials haven't shown any real advantage. Not many people I know use it other than maybe. May have role in specific cases, maybe. DFI, again, it's a technology that's within the scope. And EUS elastography, this comes as a package in the in your endoscopy system, ultrasound system that you buy, the processor has this built in it. Now, the cost of this particular processor versus if you don't have these is quite significant. So you have to really see whether you need these in your routine practice or not. And I'll have, at the end of the talk, I'll have opinion from Mustafa and Khalid and Dean. But I don't think I know many people who have actually had much benefit from these. Maybe there will be a time to have really look at it. So what do you do with pancreatic cysts? We've already touched on it. So if you're going to just aspirate, it's always good to aspirate with 19, especially if you're thinking that there's going to be thick fluid there. And mucoid fluid is not easy to come out with 22G, so 19 is better. And this is where USFNA still has a role. What do you do with liver biopsy? 19G is better than 22G, FNB rather than FNA, wet section rather than slow pull, heparinized needles, use stylet to keep specimen intact, single pass with 3 actuations. This is what is recommended, but you make 2 passes. If you don't get tissue, what do you do? While disengaging from scope, that's very important, and I'll show you a video. That's Dr. Khalid's video. Tissue express slowly with stylet over to this is very important. Keeping your needle straight and bringing it out slowly, because you want that core to come. So hopefully this will play. Yes, it will. So I borrowed this from Dr. Khalid. So you identify the easiest is obviously left lobe, as we discussed. So you can see the needle coming out. And again, fanning 4 to 5 times. See, advantage of holding the needle like this, and we'll just show you that you have more control. But you can see the liver is up to here now. So you can go, you've got a nice passage. You need to make sure there's no vacuum. Now this is important. इसको आप बात कर लेते हैं. I wanted you to see. They're keeping this almost straight. So now you're keeping that end straight and very slowly advancing the. That's a nice score, and even you can see it obviously with the. Once you've got a core that's that long, I think you're comfortable that you've got reasonable. So right lobe, you need to go where? How will you get the right lobe? So this is what this course has done. You don't have to think. You know now where you're going to go and do what. It's important, obviously, you want to select an area where obviously there are no vessels. Although again, when they're doing ultrasound guided liver biopsy, so what are the advantages? I think if it wasn't for cost, I would think this is probably a better way of doing liver biopsy, but obviously this is very expensive. More comfortable experience. Most patients don't have any pain. Ability to do biliver biopsies, real-time imaging when you're doing biopsy, comparable or better than percutaneous or transjugular. Adequacy for pathology interpretation nearly 100%. So you get enough portal tracks to see if you've done it properly. So I think if it wasn't for cost and I wanted to have a liver biopsy, then I would probably ask you to do an EUS guided, but I think cost is seriously prohibiting, especially with the amount of liver disease we have in our country. What about lymph nodes? Again, very good sensitivity and positive predictive value, specificity, accuracy, and negative predictive value. And the new needles and cutting needles, safe method, valuable, good core, the high quality of histological cores and the good amount of tissue allowed complete histochemical analysis. So the problem with lymph nodes is you really want good tissue so that you can properly assess the tissue and differentiate between different lymphomas. So genomic profiling in pancreatic cancer is important, biliary more and more important. Bile duct cancers have alterations that be assessed and then can be targeted. The bottom line is what I think is important. About 18% of patients undergoing CGP exhibited potentially actionable mutation, highlighting the potential for personalized therapeutic approaches. Now, we are a little away from that. However, if you want it, there is a system of sending sample if you want to, but there is prohibiting costs for assessment and also for obviously treatment. Immunotherapy is extremely expensive. This is a new thing. I have no experience with this. This is through the needle biopsy forceps. Good for cystic walls, they say, but I personally have no experience. So Khalid and Mustafa and Nadeem may have used it. And what about digital confocal laser microscopy? Again, I think it's not really in use in most centers. And I know that Mustafa and Khalid have used it, but I didn't get a very good positive. Okay, so bottom line is you have a pancreatic solid lesion. Pre-procedural assessment is important. So you need to know what you need, what is actually required here. So lesion assessment. And then when you come down to doing the procedure, FNB needle, if it's available to you, any of the Francine fork actually is whatever is available is pretty good. 22G is preferred. 25G usually when you're in the D2 and you're trying to biopsy from there, sometimes it's difficult to bring the 22G needle out, and if you feel that, you can use 25. Otherwise, I've not used 25. Most of the D2 as well, we can almost always do 22G. So 22G is the size. FNB, any end cutting needle is probably the same. Technique is fanning, almost universal now. whichever technique of actually taking the tissue out, whether you do wet suctions, dry suction, slow pull, or without the stylet, I think it's something that will vary from person to person and their experience. 2 needle passes should be the minimum. And if you have rows, I think it's a good learning exercise, and it's something that I would recommend. It doesn't really cost us, but this is modified rows. Actual rows, you need to have a cytopathologist assess at the same time. But now I think with the newer technology, you can actually bypass that. With that, thank you very much.
Extend it a little bit out. So the lower part, the lower thing, when and how should we adjust that? The upper is for the needle to come out. Yes, yes.
Fresh from if you're needing and using a fresh needle first time, then you don't need to adjust anything. You just go in, target your lesion, advance your needle. If you feel any resistance in the needle, there is a problem. You don't need to push. It just literally goes without any resistance. If you're doing it second time, when somebody has actually moved it, it's important to check whether your sheath is out or not. Sheath should be a little bit out for your needle to actually go smoothly. You can actually see it on EUS as well as endoscopically. If you are reeved, it's mandatory to check the sheath, because when it's washed and clean, the sheath is moved up or down. It's very important to bring the sheath out as you go in first, see it out, put it back to where you want it, and then advance it. Otherwise, you'll damage it. Otherwise, sheath you don't need. Sheath is just protecting you. And then that's where I'm sorry, I said that,
So the principle is that you need to know where your sheath is in relationship to the probe and the lesion, right? The different needles come out preset at different settings on their sheath based on how they're packaged. And you need to know the distance for that needle for when it comes out, and also where it will come out of the needle channel. The safest thing, and I usually teach the fellows to do this, is to pull it back to about 1 centimeters outside. And actually, under EUS guidance, open your elevator and advance the sheath first and visualize the sheath. Especially early on, there's a tendency to just quickly get it down and puncture. But slow yourself down, visualize the sheath, because once you see the sheath, there's more of a chance to see the needle. Otherwise, if you're not seeing your sheath and you start puncturing, and you're like, I lost the
to the sheath, and sheath starts feeling that handle again, because and then lock it there, because if you don't lock it there, there's going to be gap and sheath's going to come back. Okay, so there are like these little bit nuances you need to be aware of that, and that comes with sticking to, if you're doing a lot of these cases and use different type of needles, you will get familiar with those needles. But if you have only 1 needle or 2 needle to use, you need to understand the mechanics of the needle. You need to understand the whole structure of the needle, sheath, material, how it's going to get affected with the use of elevator. Is the stylet sharp? It's blunt? Is it going to be, when it comes, is it outside? Is it protecting the sharp edges or not? So just whatever you're familiar with, just study that needle, okay? Right? Because you, here in this country, in this setup, you're not going to have access to every needle. You have to pick 1 or 2, at the most, probably 1. For us, all those needles are available. And because there are So many of us, and each has a different preference of using. I usually say all these needles out there, they all work. You just need to figure out how it works and how it works for you. Okay. Yeah, you mentioned it. But yeah, he did. Oh, sorry. I'm sorry.